And our next guest will turn to community health. Please welcome Dr. Stanley K.F. TAM, President of the Hong Kong Geriatrics Society, to discuss early cardiovascular disease screening from guidelines to community implementation.
This is the pointer. This is fast forward, backwards.
Over to you, Dr. Tam.
Thank you for the invitation. It's my pleasure to share with you these topics. I'm not a scientist. I'm a doctor working in the hospital authority. I'm seeing patients in the hospital and the clinics. So we all know the cerebro-cardiovascular disease is a group of disorder of heart and blood vessel with including coronary artery disease and stroke and other items. And this is the world's #1 killer followed by cancer, respiratory disease, and accounting for 1/3 of the global deaths. So what about the data in Hong Kong? In 2023, we have 11,000 deaths due to cardiovascular disease, accounting to 30.5 deaths per day. Among this data, 7,000 die of heart disease, equivalent to around 20 deaths per day. So we all know there are a number of modifiable and more non-modifiable risk factors that increase the risk of developing CVD, which act independently and also have adductive effects. So more risk factors, obviously higher risk. These risk factors, including some behavioral risk factors, cigarette smoking, a lot of alcohol drinking, physical inactivity, and unhealthy diet, and some modifiable biomedical risk factors, obesity, high blood pressure, sugar, lipid, and some non-modifiable risk factors such as the advancing age, family history, gender. So from Hong Kong Population Health Survey in 2020, we have some data. More than half of the person have overweight or obese. More in the males and older age group, and 43% undiagnosed. For blood pressure, 1/3 have high blood pressure or hypertension. And again, 41% undiagnosed. For sugar, 8.5% has diabetes and 36% undiagnosed. Lipid, half of them have hypercholesterolemia. If we take the level of total cholesterol, 5.2 millimole per liter. And this time the male is equal to female. Okay, very fair. Okay, 70% undiagnosed. So if we apply the Framingham risk model to predict the risk of cardiovascular outcomes among our Hong Kong people, among asymptomatic person aged 40 to 74 living in the community, we find 80.4% have high risk, equivalent to more than or equal to 20% risk of cardiovascular disease over the next 10 years. So it's more higher in the male than the female, higher in those with older age than with the younger age. And only 38% of them have received drug therapy and have received counseling to prevent heart attack and stroke. So another main bulk has not aware of this, undiagnosed. So there are a lot of international guidelines on the primary prevention of cardiovascular disease, including the United States, the Europe, the Australia, and the UK. All of them said that CVD are preventable because over 90% of heart attack and stroke attributed to 9 to 10 potentially modifiable behavioral and biomedical risk factors that we have mentioned. And this is a population-based prospective cohort study of more than 500,000 adults in the United States, They observed that unfavorable lifestyle was associated with higher risk, which was equivalent to 2.5 times to die from CVD compared with faithful lifestyle. So this is very simple and straightforward message, but the difficulty is how to implement. So the most important point is have the early identification of these risk factors and to prevent the cardiovascular disease using healthy lifestyle and medication to reduce the risk. So here is the life essential age, which was defined by the American Heart Association, which include, of course, 8 items, including 4 behavioral items and 4 biomedical items: lipid, sugar, obesity, lipid, hypertension. These are key measures to improve and maintain cardiovascular health and to lower the risk of heart disease and stroke. And there's the employment of the calculator to identify the risk for people without clinical cerebrovascular disease. There's 2, and one of them is SCORE-2, the Systemic Coronary Risk Evaluation tool, which was presented from the Europe, and one from the PREVENT, the risk education calculation from the American Heart Association. So this is the smartphone app for SCORE-2. And this is the online calculator from PREVENT. So the 2 scores are similar in using data such as the gender, age, smoking, the blood pressure, use of medication, the lipid and the use of medication, the data about diabetes and the renal function. So this is an example of SCORE-2. After the risk estimation, there will be individual level intervention and treatment goals, including lifestyle treatment, risk factor treatment, etc. So for example, in this gentleman, if they're age of 50 to 69 with estimated 10-year CVD risk of more than or equal to 10, there will be a target on the blood pressure and the target on the LDL. The target blood pressure should be less than 140 systolic, and the LDL should be less than 2.6 millimole per liter. So, and NICE guideline also recommend the usage of medication such as atorvastatin for the treatment of the lipid. So the 2 calculators are similar, but the PREVENT calculator calculation of the long-term risk, which is more helpful for the younger individuals. But bear in mind, these calculators derive from cohort from distinct population characteristics, so should have consideration with and applying these calculators across different populations. Of course, these calculators have limitation because the lack of direct disease visualization and potential underestimate or overestimates the risk. Say, for example, a low or intermediate risk individuals may already have significant subclinical disease that was difficult to be detected by these calculators. And there was a limited personalization because there's less accurate in certain subgroup or ethnic group. And that's definitely insufficient sensitive to detect early disease. So that's why we have the cardiovascular imaging in prevention. So these are the commonly used or discussed among literatures on the cardiovascular imaging used in primary prevention, including the coronary artery calcium scoring, carotid intima, media thickness, plaque assessment, echocardiogram, cardiac MR, and CT angio. They have the use beneficial in direct visualization and quantification of the subclinical factors that the clinical assessment that may miss, and because they can detect subclinical disease and allow earlier intervention. And they enhance the risk stratification, and because they can identify the high-risk individual who might be missed by conventional risk score and provide personalized preventive strategies. Say, for example, the individuals with high CAC score will justify more intensive treatment, even the calculator score is low. But of course, this is not for everyone because this should be reserved, the guideline recommended should be reserved for intermediate risk patients or those with strong family history, because there was a risk of false positive and overdiagnosis leading to unnecessary testing or treatment, and also unnecessary anxiety. So it should be a complementary, not a replacement of the traditional risk factor assessment. And there's an issue on the accessibility, cost, and radiation. So you may also heard of the active aging proposed by the WHO. This is the model of effect of compression of morbidity. The red line show deterioration of the function with aging. You get older and the function deteriorate. The yellow line is a idealistic model that there was a postponement of the onset of chronic disease, so the individual functioning remain active till the very end of the life. So theoretically, the compression of morbidity can delay the onset of morbidity, delay the onset of mortality, so the individuals can enjoy an extended healthy lifespan. And there is a compression of morbidity, so they have less years live with disease or unhealthy years. So to do this, we need to have postpone or avoid chronic disease. To avoid this, we have to do it early, not at the elderly age group. So this comes the life course preventive care in primary health care, advocated by the Hong Kong reference framework, which aim to minimize the development and accumulation of risk factor across a lifetime. Go back to this health survey. But what about the risk factor of the middle-aged adults in Hong Kong? You can see that hypertension occurred in 1/3 of them, around diabetes 8.9%, hyperlipidemia half, obesity more than half, and there should be another column at the bottom. 15% has smoking, so they are not healthy. If we do the project 10-year cardiovascular risk using the Framingham score, more than 80.4% have more than 10 or equal to 10% of risk of developing cardiovascular disease in the coming 10 years. Especially high risk in the males, smokers, and diabetes. So something had to be done. So the government advocated screening of these triple H, blood pressure, sugar, and lipid. The blood pressure, the government recommend the screening every 2 years and annually for older adults. For diabetes, the screening every 3 years and annually when risk factors are present. So you may be aware that there's data for diabetes diagnosis. The HbA1c was more than or equal to 6.5. But there's another category of pre-diabetics. The guideline for diagnosis is 5.7 to 6.4. 5.7 is very easy to achieve. So so it's very alarming if you check the HbA1c. So okay. The hyperlipidemia should be recommended to check it every 3 years and annually when risk factors are present. For the healthy adult, the desirable LDL target is 2.6 mmol per liter. And for those with 10-year cardiovascular risk of less than 20%. For those with high risk, including those with 10 years cardiovascular risk of more than 20%, the target should be LDL target was 1.8. And also we screen for obesity. To do this, the government has recently advocated the chronic disease co-care pilot scheme, the 慢病共治先導計劃. This is a 3-year project to subsidize the middle-age group with no known history of this diabetes, hypertension, and hyperlipidemia to provide undergo screening in private healthcare sectors with the support of the district health center and for receive care from the family doctors. So in summary, cardiovascular disease remains a leading cause of morbidity and mortality, and preventive strategies have shown promising results in reducing incidence and recurrence of the cardiovascular disease. And the primary prevention includes the identifying risk factors, estimating the risk, and maintaining a healthy lifestyle, addressing the modifiable risk factors, including the hypertension, lipid, sugar, and body weight. And cardiovascular imaging have the role of strengthening the primary prevention by uncovering the hidden risks, provide objective disease markers, reduce the incidence when combined with conventional preventive strategies. And this is an AI generated picture. So hopefully in the future we can do very simple early cardiovascular disease screening just at the clinic using simple technique that we can see in the future. Thank you.
Thank you, Dr. Tam. Please stay with us. Now, I'd like to invite Professor Chun-Yi Ji to present the souvenir to Dr. Tam.